Up until now, we've built almost everything we need to read an ECG. We learned that leads give us direction, and the paper give us amplitude and time. But one question is still missing. Where exactly do we place the electrodes? And why there and not somewhere else? The answer doesn't start with the ECG machine. It starts with the heart itself. Not the electricity it makes, but where it actually sits and which way it's pointing. Most people imagine the heart sitting upright in the chest, centered, symmetrical, like a diagram in a textbook. But that's not quite right. The heart sits in the mediastinum, the space between the lungs. And it's found slightly left of center. And it isn't sitting upright. It's tilted. The base, where the great vessels enter, sits more up and behind. And the apex points the other way, downward, forward, and to the left. This is important. And this is why you feel your heartbeat at the left side of your chest. That's the apex, tapping against the chest wall with every beat. Now think about what that means electrically. Electrical activity isn't generated equally by every part of the heart. The more muscle cells depolarizing, the stronger the electrical signal produced. And most of the heart's muscle mass belongs to the left ventricle. The left ventricle forms much of the apex. So when the ventricles depolarize, the overall electrical wave doesn't move randomly. It has a dominant direction, downward, forward, and to the left, towards the apex. This is the natural direction of the heart's electricity. And electrode placement was designed around it. Lead placement isn't random. It was built around the heart's natural electrical direction. More than 100 years ago, a physician named Einthoven asked exactly that question. If we wanted to watch the heart from multiple angles, where should the detectors go? And his answer was simple. Place one electrode on the right arm, one on the left arm, one on the left leg, and one more on the right leg. But the right leg isn't used to create a lead. It mainly serves as a reference electrode, helping reduce electrical noise. The other three electrodes become our important points. 3 points, 3 electrical reference points around the heart. Connect them and create an imaginary triangle. This triangle is called the Einthoven's triangle. And the heart doesn't sit at the geometric center of this triangle, but electrically, we treat it as if it does. And by comparing electrical signals between different corners of that triangle, we create leads, different viewpoints watching the same heart. Now let's talk about the three main leads. Lead 1. We have a negative electrode in the right arm and a positive electrode in the left arm. It looks for electricity moving towards the left side of the body, towards the positive pole. Lead 2. We have a negative electrode in the right arm and a positive electrode in the left leg. It looks for electricity moving from the upper right part of the body towards the lower left part of the body. And this direction aligns closely with the heart's natural electrical axis, downward and to the left. So lead 2 often sees the main electrical wave almost head-on. This is why lead 2 usually gives us one of the clearest and most upright signals. Lead 3, left arm negative, left leg positive. It looks from the upper left part of the body towards the lower right part of the body, watching from another angle. 3 leads, 3 viewpoints, all watching the same electrical event from the frontal plane. The heart sits tilted inside the chest, and its electrical activity has a preferred direction. And because of that, where we place our detectors matters. Einthoven surrounded the heart with 3 points. 3 leads gave us 3 angles. But 3 angles still aren't enough. So 3 more leads were added called augmented leads. These new leads work a bit differently. We will talk about them in the next video. That's all. Thank you and see you in the next video.